We are talking about a 63 years old male former smoker, heavy smoker, 55 peg years, COPD gold stage 4, FEV1 29% predicted, TLC 128% predicted, suffering from hyperinflation. He had sufficient treatment regarding to GOLD guidelines. He was suffering from respiratory failure type 1, which is hypoxemic, and he was on long-term oxygen for 24 hours per day. The last visit in our outpatient clinic was 18 months ago. But if you're going to ask him, you see that he had 5 exacerbations requiring an ICU stay within these 18 months. So he was one of those COPD patients suffering from repeated exacerbations being hospitalized due to an acute severe exacerbation. And this time, he came to our ICU, or firstly to our emergency department, and he was discharged 9 weeks before from another hospital. He had increased sputum, he had increased dyspnea, and he had acute on chronic respiratory failure, as you can see in his blood gas analysis, performed with 5 liters of oxygen per minute, which is quite high, honestly. The PaO2, nevertheless, was 50 millimeters of mercury. Well, that's okay. PaCO2 was nearly 80 millimeters of mercury, and he was acidotic. But you see, bicarbonate is high as well, so he was suffering from acute on chronic hypercapnic respiratory failure with severe acidotic respiratory failure. So what we have done is we have started non-invasive ventilation in the emergency department. The patient was transferred to our ICU. We were treating him with non-invasive ventilation in the acute phase, and we were successful. I don't talk now with you about treatment algorithm, about ventilation parameters for treating acute hypercapnic respiratory failure, because we are talking about long-term non-invasive ventilation. So we were treating the acute respiratory failure successfully on our ICU. And then the patient was transferred to the general ward. He had no chance to receive rehab. In the German system, you can receive rehab once. It's not an ambulatory rehab system. The majority of patients are going inside a rehab unit, performing rehab. And once you have had rehab due to COPD, it's really hard to get another rehab session from your health insurance company. So we had no chance to send him to rehab. And he had symptoms of chronic hypercapnia, like morning headache, like sleep disruption. He was suffering from edema. As you might know, CO2 is a strong vasodilator, and edema is not always heart insufficiency. It can also be chronic hypercapnia. So on our general ward, we performed another blood gas analysis with 2 liters of oxygen per minute now, and it was 3 days after we terminated acute non-invasive ventilation. And as you can see, he's not acidotic anymore, which is good. But he is still hypercapnic. PaCO2 is 63 millimeters of mercury with a bicarbonate of 32 millimole per liter. So he now suffers from chronic respiratory failure. So I would like to see your hands. Well, no, first of all, I will show you some other data about the patient. Blood sample, X-ray, no signs of infection. Echocardiography, mild signs of pulmonary hypertension. Well, he suffers from severe COPD. Polygraphy, no sleep disorder breathing. So the diagnosis, as pointed out before, is chronic respiratory failure type 2, which is hypercapnic, due to COPD gold stage 4 after acute hypercapnia. Blood gases performed 3 days after terminating NIV. Who would start non-invasive ventilation in this patient? Please raise the hand. So it's 10. 11. Well, now you can say, well, you're kidding. You are like Donald Trump. 10 minutes before, you told us, well, you should start home mechanical ventilation after acute hypercapnic respiratory failure at least by waiting 2 or 3 weeks. And now you're telling me you start non-invasive ventilation for home mechanical ventilation after 3 days of terminating acute non-invasive ventilation. Well, the thing is, this patient had 5 acute exacerbations with the need of mechanical ventilation on an ICU in the last 18 months. He is suffering from chronic respiratory failure, but he has severe acute on chronic respiratory failures repeatedly. And that was the point where we said we start non-invasive ventilation in this patient. So, and this is really important, we discussed and we explained home mechanical ventilation to the patient. Although he used it several times before in an acute phase, you should explain your patient what it means to use a mask, why he should use a mask, because it's not natural. And if you don't understand why you should use a mask, you will not take the mask. So we decided together with the patient to start home mechanical ventilation, and we needed from that day on 4 days on our respiratory ward to get NIV carefully established. The first aim is to get the patient familiar with the device, with the mask, and with non-invasive ventilation. And therefore you need several days. You need several days to take care about leakage, to find a fitting mask. And as I pointed out before, you need higher pressures in COPD patients. You don't need 15 or 50 millibar is not enough in the majority of COPD patients. If I give you 50 millibar on the mask, you will easily tolerate it. But if I give you 23 millibar on the mask for the first time, you will not tolerate it at all. So it takes some time to perform blood gases to see if CO2 goes down. If CO2 is not going down, you have to increase pressure levels slightly. The patient has to get familiar again with non-invasive ventilation. And all these things, carefully increasing inspiratory positive airway pressure, performing mask management, explaining NIV to the patient, performing blood gas analysis to see if the pressure level is sufficient to significantly decrease elevated pCO2 takes several days. Sometimes it takes 2 days, sometimes it takes 6 days in COPD patients. This was the blood gas analysis at night before we started home mechanical ventilation with 3 liters of oxygen per minute, PaO2 53 millimeters of mercury, and PaCO2 69 millimeters of mercury, pH in the normal range. At the end of the 4 days, we ended with a mean inspiratory positive airway pressure of 24 millibars. We started with 14, and we were increasing inspiratory positive airway pressure slightly over the 4 days. Expiratory positive airway pressure was 4 because, as pointed out before, he had no sleep disordered breathing. We used a breathing frequency of 18 breaths per minute in order to achieve some kind of controlled ventilation. And we used an inspiratory time of 1 second. And by using this ventilatory strategy, at the night before discharging the patient, PaCO2 was dropping down from 69 to 51 millimeters of mercury, which is a good result. He's not normocapnic, but I don't care about normocapnia as long as you are significantly reducing CO2, because you want to see that you are treating him sufficiently with home mechanical ventilation. And one of the best parameters to get an idea if the treatment strategy is good, you are giving your chronic hypercapnic patient, is to look at CO2. And this is another important issue. What happens to the patient now? Do you see him again? When do you see him again? Do you perform a control visit with regard to home mechanical ventilation? And we have guidelines in Germany, as I pointed out before, and these guidelines were published for the first time in 2010. The new guidelines will come out, the updated ones in 2017. And we don't only have them in German, we also have them in English. And it says the first ventilation control visit must occur in the short term, which is 4 to 8 weeks, and therapeutic success is evaluated according to subjective, clinical, and technically measurable parameters. So between 4 to 8 weeks. We have seen our patient 6 weeks after initiation of NIV. This is the normal algorithm we are doing in my clinic. And Symptoms were good. He had no morning headache anymore. He said his concentration improved. Well, his wife said his concentration improved. He still had reduced exercise capacity, of course, but he had no peripheral edema, and we did not apply any, or we did not prescribe any kind of diuretics. So what about blood gas analysis? This was again blood gas analysis at night prior discharge with NIV, which I have shown you before, and this is the blood gas analysis at night under non-invasive ventilation again, both under non-invasive ventilation, and you see there was a slightly further decrease of PCO2, 48 millimeters of mercury. What about daytime blood gases? These were daytime blood gases before we started home mechanical ventilation. And these are daytime blood gases now with a PCO2 of 46 millimeters of mercury. No changes in ventilator settings at all. Because that's good. We were happy, the patient was happy, we did not change ventilator settings. If we think anything is not good, we would change ventilator settings. And what happens then? And we also have recommendations for the longer period where we say it is recommended that further control visits are carried out 1 to 2 times a year regarding COPD patients. So if he's completely stable, if he's confident with everything, 1 year is enough for controlling NIV. But you should control NIV to see if he's using the device, if the mask fits, how blood gases are. It might be that he loses weight and then he's maybe hyperventilated because he lost weight. Everything can happen. So the second control visit was 9 months after we started NIV. He still had no symptoms of chronic respiratory failure. He used his NIV every night for 6 to 8 hours. He also used NIV during daytime for 1 to 2 hours. This happens a lot. If the patient gets the feeling that it helps, they are using it for having a nap after lunch, for example. And he had 1 mild exacerbation without hospitalization. And blood gas analysis at night was 43 millimeters of mercury, PCO2. And during daytime, without non-invasive ventilation, still 46. So that's the case. That's the first part, optimizing discharge in severe COPD patients. I have talked a lot about non-invasive ventilation being prescribed after acute respiratory failure. We have talked about home mechanical ventilation in COPD. I have shown you a case, and if you have any questions for the first part now, please feel free to address. Yes, please.
Thank you for the presentation. I have a question regarding the first part. We heard yesterday about the recommendations in Denmark to start patients above 50 millimeters of mercury in PCO2 levels above 50 and or exacerbations in the last 12-month period, I think. Do you also start patients with 50 millimeters of mercury in PCO2 without exacerbations?
Yes, we do.
Okay.
Our algorithm is we start home mechanical ventilation if daytime PaCO2 is higher than 50 millimeters of mercury and or nighttime PaCO2 is higher than 55 millimeters of mercury. Yeah? So daytime higher than 50, nighttime higher than 55 millimeters of mercury during spontaneous breathing in stable hypercapnic COPD patients. Then we would start home mechanical ventilation. We will start home mechanical ventilation if we have acute and chronic respiratory failure. As I am one of the authors of the new guideline, I can tell you that in the new guidelines we will say you should wait 2 to 3 weeks after acute respiratory failure has been treated sufficiently. And if the patient is still hypercapnic, PCO2 higher than 50 during daytime, PCO2 higher than 55 during nighttime, then you have a chronic respiratory failure patient, start NIV. And there are also some individual decisions, like the one I have shown you in the case study, because we didn't wait for two to 3 weeks, because I had the fear, if you're going to wait for 3 weeks, he might come back with another acute hypercapnic respiratory failure. So if you have somebody who comes to the hospital with several repeated acute hypercapnic respiratory failures needing mechanical ventilation, I think you can also think about starting home mechanical ventilation.
I have a second question also. Do you have any concerns regarding right ventricular function in these patients? Do you have any problems with the high pressures?
Nothing at all. No problems at all.
Okay, thank you.
We have performed a study. I didn't show you the results because it was not the topic, but we have done a study where we have shown, where we looked at cardiovascular biomarkers and inflammatory biomarkers before starting home mechanical ventilation and after 2 months of home mechanical ventilation. And we have seen that there is some kind of signal with regard to the inflammatory markers, which we don't know. But we have seen that there is a decrease in BNP levels, a significant decrease, without adjusting any kind of diuretics. And it might be that we are interfering with fluid levels due to COPD being a vasodilator. It might also be that we have any kind of protective cardiovascular effects. For example, improving pulmonary hypertension and so on. We don't know, but at least BNP goes down and doesn't go up, so we don't have any fear about cardiac side effects. Yes, please.
My turn. Do you have any concerns considering emphysema and high pressures?
Not at all.
So how high would you go?
Well, we have ventilated COPD patients up to 40 millibar inspiratory positive airway pressure. Before your lung explode, your mask will go away. I mean, that's I'm ventilating COPD patients for, I would say now, 13, 14 years. And in the former days, we were using really high pressures because we performed these small physiological studies. Comparing 2 opposite treatment strategies. And you must think about, if you have 30 millibar in your ventilator, in the tube you have a loss of pressure, in the mask you have a loss of pressure. If you measure the pressure in the mask, you have 30 millibar in the ventilator, you have about 25 millibar in the mask. You might have about 18 millibar in the trachea, because you have leakage, you have the upper airway where you have a loss of pressure. And at the end of the day, from the 30 millibar, you might have 50 millibar within your lungs. So, and before you get a pneumothorax, you have leakage. So I have seen pneumothorax in patients on non-invasive ventilation, but they were performing non-invasive ventilation for several weeks, years, and they had a pneumothorax, like some COPD patients have pneumothorax, but I have never seen a pneumothorax in starting NIV where I can directly link the pneumothorax to NIV. And I think it's some kind of physiological, or you can explain it physiological due to the pressure loss. It's not invasive mechanical ventilation. If you take 30 millibar invasive mechanical ventilation, you get the 30 millibar within your lungs because you don't have leakage, you don't have a lot of pressure loss in the upper airway, but non-invasive ventilation is different. And that's why the lower pressures do not work. If you have 50 millibar on your vent, you might have 6 or 7 millibar within your lungs. And that's sometimes enough for ALS patients and neuromuscular patients. That works perfectly, but it doesn't work in COPD.
Is there any concerns about the EPAP then?
Yeah, well, we have no idea about the EPAP, to be honest, because in the former days we were all looking on IPAP, but nowadays we are thinking about EPAP. We are thinking about counterbalance dynamic hyperinflation, which is part of my second talk. Oops, what happens now? And we are, I think in the future we will think about end expiratory positive airway pressure quite more. The statement I can give you now is if you have sleep disorder breathing, increase your end expiratory positive airway pressure, of course, in order to not only treat chronic hypercapnia, but also treat sleep disorder breathing.
Yeah, I wonder what is your advice to the patient? How many hours should he at least use the?
6 hours per night at least.
Yeah, and
If he uses it 4, okay. If somebody use it less than 4 hours during 24 hours, we talk to him, and if he only use it 2 to 3 hours, we don't give him NIV.
And it's always preferable also to use it daytime? But could they use it only
No,
day?
well, we recommend to use it during the night. We don't recommend to use it during the daytime. I will talk a lot about NIV during daytime exercise now, but we recommend for home mechanical ventilation, for treating chronic hypercapnia, using NIV during the night. And if they feel good and they want to use it for 1 or 2 hours during the day, they can use it during the day.
Thank you.
You're welcome.
I would like just to touch a little bit on oxygen. Since you're using NIV, oxygen by night is most of the time not necessary anymore, because you improve FRC, etc., etc. But I have a little bit of problems getting the pulmonologist at my department to understand that maybe a portable device would be good. If you want to rehabilitate a patient and the patient should move a little bit and they have a diffusion damage, it's not really a very good test to put on a saturation monitor while being still, not being under exercise. Can you tell us a little bit more about that?
Yeah, we prescribe oxygen if you have hypoxemia at rest. If PaO2, blood gas analysis, PaO2 is below 55 millimeters of mercury. We also prescribe oxygen if PaO2 is below 55 millimeters of mercury after 6-minute walking test. So we are also assessing oxygenation during exercise. If we have somebody with a PaO2 at rest of 58, 59 millimeters of mercury, but he's suffering from dyspnea during exertion, we are performing blood gas analysis before and after 6-minute walking test. And then we are allowed to prescribe it in Germany, and then we prescribe fluid oxygen in order to carry the oxygen.
Hello. Just to get it clarified about the patient that you wait 2-3 weeks after the acute exacerbation, it must be the patient that where you have no knowledge about their story, about their chronic hypercapnic state.
Yeah.
In this patient, you wait. The other,
Yes.
you start up.
If we have somebody where we know he suffered from chronic hypercapnia half a year before and he now has an acute episode, we would think about treating him with home mechanical ventilation. But we have a lot of patients coming to our ICU for the first time with acute hypercapnic respiratory failure. We treat them with NIV, and then we don't have any idea, is he hypercapnic because he's suffering from acute hypercapnic respiratory failure, or is he hypercapnic because he was suffering from chronic hypercapnia before and now has acute on chronic hypercapnic respiratory failure?
Thank you very much.
You're welcome.
Very interesting lecture, and I
Thank
come
you.
from Norway, and as you might know, we have national guidelines in Norway that do not recommend NIV in COPD patients.
Yeah.
I have several questions. Do you think the recommendations that you give us, that they will do, what will they do with the time that you spend with these patients and what you say, the in-night patients, the number of nights?
Well,
you say you use 2 to 6 nights to make sure that everything's okay.
We are coming. Well, I think it takes time. 4 years ago, we didn't have any data about mortality rate, which is a hard outcome, and therefore, beside some countries, a lot of countries like the US, for example, are not treating COPD patients with chronic respiratory failure using NIV. It takes another several years until we are coming to the point where I think we might have a widespread of NIV. But if you use NIV in COPD patients, you need a longer time for starting NIV. Not a lot of countries are able, due to their healthcare system, to take patients inside the hospital for 1 night, 5 nights, 3 nights, like the US. And I think we should think about, and this is where the scientific world is drifting towards, think about starting home mechanical ventilation in an ambulatory setting, which my personal point of view will work perfectly in neuromuscular patients, will work in restrictive disorders, but in COPD patients it's really difficult due to the fact that I have pointed out before. You need higher pressures, you have hyperinflation, and you need several times. But there is a Dutch study which currently assesses if non-invasive ventilation can be started outside the hospital in COPD patients.
But do you